Somewhere in the first hour after dinner, a familiar burning appears in the chest, not painful exactly. More of a warmth or a pressure that settles behind the sternum and sometimes reaches up toward the throat, and the almost universal response is to reach for an antacid, because this is what happens after a big meal. This is what has been happening for years, and the antacid takes the edge off it well enough that the concern dissolves along with the sensation, and the evening continues. What most people never consider in that moment, and what most doctors do not have time to explore in a standard appointment, when a patient mentions occasional heartburn, is that the chest burning that follows a large meal has two completely different physiological origins that produce symptoms so similar they are frequently indistinguishable from the inside, and that one of those origins is entirely benign, while the other reflects a heart muscle that is not receiving adequate blood supply during a period of increased demand, and that in an adult over 60 with any cardiovascular risk factors, the probability that the second explanation is contributing is higher than most people have ever been told. This is the clinical overlap I want to talk about today, not to frighten you away from your antacid, but to give you the specific framework for knowing when the burning behind the sternum deserves more than a calcium carbonate tablet and a familiar dismissal. Before anything else, what I share in this video is educational information only. It is not medical advice. If you experience chest burning or pressure that is severe, that lasts more than 15 minutes, that does not respond at all to an antacid, or that is accompanied by breathlessness, sweating, nausea, or any radiation to the arm, jaw, neck, or back, please call emergency services immediately. Those features change the category from something to investigate to something to act on right now, and the treatment window for an acute cardiac event is measured in minutes, not days. What I want to give you today is the framework for what falls below that emergency threshold, but still deserves a different response than the one most adults are giving it. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. The specific reason I want to make this video is that post-meal chest burning is one of the situations in clinical medicine where the correct answer most clearly depends on which question you ask, and the question almost nobody asks is whether the meal itself just stressed the heart. Not the stomach, the heart. If this is your first time on this channel, subscribe right now because every week I bring you specific, grounded information about what your body is communicating after 60, and this video addresses one of the most clinically important and most consistently misread signals in the post-60 body. Let me start with the physiology of what a large meal does to the cardiovascular system, because this mechanism is almost never explained to patients, and it is the foundation of everything that follows. When you eat a large meal, particularly a meal high in fat and simple carbohydrates, the digestive system demands a significant increase in blood flow. The stomach, small intestine, and liver together require a roughly 2 to 3-fold increase in blood supply during active digestion compared to the fasting state. The splanchnic circulation, the network of vessels supplying the abdominal organs, dilates to accommodate this demand. Blood is redistributed from other vascular beds toward the gut. At the same time, the metabolic demands on the heart itself change. The digestion requires energy. Body temperature rises slightly during digestion, which increases metabolic rate. The autonomic nervous system shifts toward the parasympathetic mode of digestion, but the cardiovascular response to the increased visceral blood flow still requires the heart to maintain adequate output across a changed distribution of vascular resistance. For a heart with healthy coronary arteries, these changes are unremarkable. The coronary arteries dilate in response to demand. Additional flow reaches the heart muscle, and the meal is digested without any cardiac awareness. For a heart with coronary arteries that are narrowed by atherosclerotic plaque, the picture is different. The narrowed artery can deliver adequate blood flow to the heart muscle at rest when demand is low. But when demand rises, including the increased demand of the post-meal cardiovascular state, the narrowed artery cannot dilate enough to supply the additional flow the heart muscle needs. The oxygen supply falls short of the demand. The heart muscle enters a state of ischemia, the same oxygen debt that during physical exertion would produce the classic anginal chest tightness. And the sensation produced by that ischemia, the pressure, the heaviness, the burning across the front of the chest, is experienced in the post-meal setting and attributed entirely to the stomach rather than to the heart. A study published in the American Journal of Cardiology found that in adults with documented coronary artery disease, large meals produced measurable ST segment depression on electrocardiographic monitoring, the electrical signature of myocardial ischemia, in a significant proportion of patients who did not experience symptoms that they recognized as cardiac. The ischemia was real, it was measurable, and it was being driven by the cardiovascular demands of digestion in arteries that could not meet those demands. And in many of those patients, the post-meal discomfort they reported was being managed with antacids. The fat content of the meal specifically amplifies this effect. Fatty meals produce a sustained and larger increase in splanchnic blood flow compared to low-fat meals of equivalent caloric value, because fat digestion requires extended bile-dependent processing in the small intestine that prolongs the cardiovascular demand of digestion. This is the physiological basis for the common observation that the worst post-meal cardiac symptoms occur after a large, rich dinner rather than after a light breakfast, and it is a detail worth noting when describing the symptom pattern to a physician. A consistently more symptomatic response to fatty or large evening meals in an adult with cardiovascular risk factors is, in the language of cardiology, a positive dietary anginal history. The clinical challenge is the substantial overlap between the symptom of gastroesophageal reflux, which produces a burning sensation in the central chest from acid in the esophagus, and the symptom of post-meal angina, which produces a pressure, burning, or tightening sensation in the same location from ischemia in the heart muscle. Both occur after meals. Both are located in the central chest and sometimes into the throat or upper epigastrium. Both can improve with sitting upright, because the upright position reduces gastric reflux and also reduces the cardiovascular demand slightly compared to the recumbent position. Both can worsen with lying down, for the reflux reason and for the cardiac reason that the recumbent position after a large meal alters preload and can increase myocardial demand. And both can produce a burning quality in the chest that, from the inside, does not feel fundamentally different enough to point definitively toward either cause. The features that favor a cardiac, rather than gastrointestinal origin, are worth knowing precisely, because they are the discriminating information that changes the management. The first is the onset of symptoms in relation to meal size. Acid reflux is not reliably correlated with the size of the meal, in the same way that post-meal angina is. A large meal, one that demands a larger increase in splanchnic blood flow and therefore a larger cardiovascular adjustment, is more reliably angina-provoking than a small meal. If the chest burning after a modest meal is absent or mild, but consistently appears or worsens after a larger meal, that dose-response relationship with meal size is a cardiac pattern. The second is the response to physical exertion in the same period. If post-meal chest burning is accompanied by or worsened by any physical effort in the hour or two following the meal, even mild effort like climbing stairs or walking briskly, that combination of eating and exertion provoking the symptom is a classic anginal pattern. Reflux is not made reliably worse by physical exertion in the postprandial period. Post-meal angina is. The third is the response to nitrates. Glycerol trinitrate, the sublingual spray or tablet used in the acute management of angina, produces vasodilation that relieves coronary ischemia rapidly. It also reliably relaxes the lower esophageal sphincter and can reduce esophageal spasm, which means it can relieve both cardiac and esophageal chest pain. But the speed of relief is different. Cardiac angina relieved by nitrate typically responds within 2 to 3 minutes. The esophageal effect is less predictable and less rapid. The fourth is the presence of associated symptoms. Any chest burning accompanied by breathlessness, by diaphoresis, by radiation to the arm or jaw, or by a sense of unease disproportionate to the pain is not acid reflux until cardiac causes have been specifically excluded. There is a third cause worth naming specifically, because it further complicates the picture in a way that is relevant to adults over 60. Esophageal spasm, the sudden intense contraction of the esophageal muscle that produces a chest pain, sometimes described as severe enough to mimic a heart attack, and that can be triggered by eating, by cold liquids, or by emotional stress. Esophageal spasm has its own clinical features, typically a more sudden and more severe onset than either reflux or angina, a more variable relationship to meals, and an ability to radiate to the back as well as the neck and jaw, but its overlap with both cardiac and reflux symptoms is significant enough that it enters the differential diagnosis in any adult over 60 with recurrent chest pain after eating that has not been clearly explained. The reason I mention it is not to add complexity for its own sake, but to underscore the central message of this video. Post-meal chest discomfort in adults over 60 has a differential diagnosis that a standard antacid does not evaluate. The antacid manages the symptom surface. It does not tell you which of the three possible sources is producing it. Type in the comments right now whether you take antacids regularly for post-meal chest discomfort and whether your doctor has specifically discussed with you whether the symptom might have a cardiac component. Because the gap between yes and no in those comments will tell me something important about how often this clinical question is being asked in routine care. I want to describe the two forms of angina that can produce post-meal chest symptoms because they carry different levels of urgency and different management implications. Stable angina is the pattern in which the chest symptoms occur reproducibly with a predictable level of demand, including a predictable level of food intake, and resolve within 10 to 15 minutes when the demand is reduced. The person who has post-meal chest burning after large meals that has been consistently present for months, that resolves within 15 minutes of finishing eating, and that does not occur after small meals, may have stable angina from a coronary stenosis that is adequate for low demands, but insufficient for high demands. This is not an emergency at the moment it occurs, but it is an indication for cardiac evaluation and is not to be managed indefinitely with antacids, while the underlying arterial disease progresses unaddressed. Unstable angina is the pattern in which the threshold for symptoms is changing. Symptoms that were previously only occurring after large meals now occur after small meals. Symptoms that were previously resolving in 10 minutes are now taking longer. Symptoms that were previously only postprandial are now occurring at rest. Any change in the pattern of anginal symptoms in the direction of increasing frequency, lower threshold, or longer duration is unstable angina until proven otherwise, and it requires urgent cardiac evaluation, not a phone call to schedule an appointment at the next convenient time. The change in pattern reflects a change in the underlying coronary anatomy, most often the progression of a plaque toward instability, and the period between the onset of instability and an acute event is unpredictable and potentially short. And share this video right now with one person in your life who has been taking antacids for months for post-meal chest symptoms that they have never had specifically evaluated, because the distinction between a stable coronary stenosis being managed as acid reflux and an unstable one is not visible from the symptom quality. It requires a cardiac evaluation to make, and that evaluation is not happening if the symptom is being attributed entirely to the stomach. If you are not yet subscribed to this channel, tap that button now and ring the bell, because every week I bring you exactly this level of specific, clinically grounded information. I want to tell you about a patient I will call Frank, 66 years old, retired construction manager from Houston, Texas. He came to me for a general review and mentioned, almost as an aside, that he had been taking an over-the-counter antacid after dinner most evenings for about 8 months. He described a warmth and pressure in the lower chest and upper stomach that appeared about 30 to 40 minutes after dinner, lasted 20 to 30 minutes, and was well controlled by the antacid. He had mentioned it briefly to his GP, who had suggested it sounded like reflux and recommended continuing the antacid. When I asked Frank to describe what happened when the evening burning was at its worst, he mentioned that it seemed to be worse after large dinners, and that once, about 6 weeks prior, he had noticed it was accompanied by a shortness of breath for about 10 minutes that he had attributed to eating too fast. Frank had hypertension managed with medication for 8 years. His cholesterol had been elevated and was being managed with a statin. He had never been assessed for coronary artery disease beyond a standard ECG at his last annual physical, which was normal. I ordered a stress echocardiogram. The test identified significant inducible ischemia in the territory of the left anterior descending artery, the vessel that supplies the front wall of the heart, and whose obstruction produces the most clinically significant forms of coronary disease. A subsequent coronary angiogram identified a 75% stenosis, a high-grade narrowing that was sufficient to maintain flow at rest, but that restricted the additional flow the heart demanded during digestion and physical exertion. He underwent coronary intervention. The post-meal chest burning resolved entirely. The antacid that had been providing acceptable symptom management had been managing the discomfort of cardiac ischemia for 8 months, while the underlying artery narrowed to the point where intervention was necessary. Frank told me, "I had no idea the dinner was stressing my heart. I thought it was the food disagreeing with me. I told him the food was not disagreeing with you. Your heart was telling you it was working hard to keep up, and the language it chose was the same language that Heartburn uses. The distinction required a test, and the test found something worth finding. Let me now talk about the specific conditions that alter the presentation of cardiac symptoms in adults over 60 in ways that make them even harder to distinguish from gastrointestinal complaints. Diabetes changes the symptom profile of cardiac ischemia through the autonomic neuropathy we have discussed in previous videos on this channel. When the cardiac sensory nerves are damaged by chronic elevated glucose, the pain signals from the ischemic heart muscle are attenuated or absent. The person with diabetic cardiac autonomic neuropathy may experience their angina as a vague sense of unease, as breathlessness, as nausea, or as a fatigue that is slightly worse after meals, rather than as the chest pressure or burning that would alert them to its cardiac origin. This is the mechanism behind silent myocardial ischemia, which we discussed in the nighttime chest symptoms video on this channel, and it applies equally in the post-meal context. For adults with diabetes, the threshold for cardiac evaluation of any unexplained post-meal symptom, including fatigue, nausea, breathlessness, or upper abdominal discomfort, should be lower than in adults without diabetes, because the normal pain signaling system that would flag the ischemia clearly has been compromised. Hypertension also modifies the presentation of post-meal cardiac symptoms, not by impairing sensation, but by expanding the range of demands under which ischemia can occur. In a hypertensive heart with left ventricular hypertrophy, the thickened heart wall has a higher oxygen demand per unit of tissue and is more vulnerable to subendocardial ischemia when perfusion pressure drops or demand rises. The post-meal cardiovascular state in a person with hypertensive heart disease can produce the same demand-supply mismatch that a coronary stenosis would produce in a normotensive heart with thinner walls, even without significant epicardial coronary disease. Both of these conditions, diabetes and hypertension, increase the probability that a post-meal chest symptom has a cardiac component even when the symptom is mild and even when the person has never had a cardiac diagnosis. They are the two factors most worth disclosing to your doctor when describing post-meal chest symptoms because they change the prior probability of the cardiac explanation in a way that changes the appropriate investigation threshold. Before we get to the practical framework, I want to address the modifications to meal habits that can reduce the postprandial cardiac demand in adults who have been identified with, or who are at risk for, coronary artery disease, because these changes are evidence-based and often dramatically reduce the frequency and severity of post-meal symptoms, while the cardiac evaluation and any intervention are being organized. The first and most impactful change is meal size. The cardiovascular demand of digestion scales with the volume and caloric density of the meal. Splitting the same total daily food intake across 4 smaller meals rather than 2 or 3 larger ones reduces the peak splanchnic redistribution demand at each meal, and correspondingly reduces the peak demand on the coronary circulation. Adults who find their post-meal symptoms are most severe after a large dinner and minimal after a light breakfast are already observing this dose-response relationship. Redistributing the caloric load is the dietary intervention most directly targeted at the cardiac mechanism. The second change is fat and simple carbohydrate reduction at the largest meal. As we discussed, fat prolongs the duration of splanchnic demand through the extended small intestinal processing it requires, replacing a large, fat-heavy evening meal with a moderate-sized meal that is lower in fat and refined carbohydrate, and higher in protein and fiber, reduces both the peak and the duration of the postprandial cardiovascular stress. The third change is pacing after eating. Avoiding any physical exertion, including brisk walking, stair climbing, or lifting, in the 30 to 60 minutes following a meal, reduces the combined demand of digestion plus exertion that is the most reliable anginal trigger in adults with coronary disease. This is not rest as treatment. It is strategic demand management, while the underlying issue is being investigated and addressed. None of these changes treats the arterial disease. They reduce the frequency with which the disease produces symptoms. The cardiac evaluation and any indicated intervention remain the appropriate management goal. Here is the practical framework I want you to use to evaluate post-meal chest symptoms and to determine when medical evaluation is warranted. Symptoms that require emergency evaluation right now: chest burning, pressure, or tightening after a meal that has been present for more than 15 minutes without improvement. Any post-meal chest symptom accompanied by breathlessness, sweating, radiation to the arm or jaw, or a sense of severe unease. Any change in the pattern of a previously stable symptom toward greater severity, longer duration, or lower threshold. These are not reflux management situations. These are emergency evaluation situations. Symptoms that require a doctor's appointment within 1 to 2 weeks, and specifically a conversation about cardiac evaluation, post-meal chest burning that has been occurring regularly for more than 4 weeks, that does not have a clear and consistent dietary explanation, and that is accompanied by any of the discriminating cardiac features I described. Worse after larger meals, worsened by postprandial exertion, accompanied by breathlessness even mildly, or occurring in a person with diabetes, hypertension, elevated cholesterol, smoking history, or a family history of early cardiac disease. The specific investigations worth requesting when cardiac evaluation is indicated are an ECG as a baseline, a stress test or stress echocardiogram to assess for inducible ischemia, and a review of your cardiovascular risk factors in the context of the symptom. An antacid challenge, meaning a 2-week trial of proton pump inhibitor therapy, can help distinguish esophageal from cardiac causes in some cases, but it should not replace cardiac investigation where the clinical picture warrants it. A normal ECG at rest does not exclude coronary artery disease. A normal resting ECG is present in the majority of adults with stable angina, because the ischemia only occurs under demand, and the resting state produces no electrical signature of it. The stress test, which applies demand and looks for the electrical or imaging signature of ischemia during that demand, is the appropriate test. In adults who cannot perform adequate exercise on a treadmill or exercise bike due to arthritis, peripheral artery disease, or deconditioning, a pharmacological stress test using adenosine or dobutamine can apply the hemodynamic demand artificially while imaging the heart for ischemic changes. There is also a specific meal-based consideration in the preparation for and interpretation of any cardiac stress testing in adults with suspected postprandial angina. Some centers now perform postprandial stress testing specifically, applying the cardiovascular stress of a standardized meal followed by low-level exertion to reproduce the hemodynamic conditions that produce the patient's symptoms. If you have symptoms specifically in the post-meal setting that have not been reproduced on standard fasting stress testing, this is a conversation worth having with the cardiologist performing the evaluation. If you are not yet subscribed to this channel, tap that subscribe button now and ring the bell, because every week I come here to give you the specific clinical frameworks that turn a vague symptom into a specific and productive medical conversation. 4 things to carry away from this video. First, a large meal increases cardiovascular demand through the splanchnic blood flow redistribution of digestion. In a heart with coronary artery disease, this demand increase can produce ischemia, and the ischemia produces a chest sensation that is indistinguishable from acid reflux from the inside. The meal is not stressing the stomach. It is stressing the heart, and the symptoms of those 2 events overlap completely. Second, the features that distinguish post-meal angina from acid reflux are the dose-response relationship with meal size, the worsening with any postprandial physical effort, the accompanying symptoms of breathlessness or radiation, and the presence of cardiovascular risk factors, including diabetes, hypertension, elevated cholesterol, and smoking history. Any of these features alongside post-meal chest burning changes the evaluation pathway. Third, stable post-meal angina from a coronary stenosis can produce symptoms that are adequately managed by antacids for months, because the antacid blunts the burning quality that is the subjective surface of the ischemia. The cardiac disease progresses during those months. Unstable angina, recognizable by a changing pattern, requires urgent evaluation, because the window between pattern change and acute event is unpredictable. Fourth, diabetes and hypertension each modify the typical presentation of cardiac ischemia in ways that make it more likely to be attributed to non-cardiac causes. Adults with either condition who experience post-meal chest symptoms have a higher prior probability of a cardiac explanation and a lower appropriate threshold for investigation than the general population. The burning behind the sternum after dinner is one of the body's most commonly misread messages. Most of the time it is the stomach. Some of the time, particularly in adults over 60 with cardiovascular risk factors, it is the heart sending its signal through the only channel that reaches the conscious mind from behind the breastbone and that channel does not differentiate between acid and ischemia. The distinction requires a clinical history, a physical examination, and the right test, and it belongs in a medical conversation rather than a pharmacy aisle. Share this video with one person in your life who takes antacids regularly and has never had a cardiac evaluation for their post-meal chest symptoms. And subscribe to this channel because every week I come here with one purpose: to give you the specific framework that turns the symptom you have been managing into the symptom you actually understand. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.